In this video, here's what we'll cover. What PTSD really is, the 4 symptom clusters, why not everyone develops PTSD, the different types of trauma, the treatments that work. Imagine you are standing in a supermarket queue when a sound behind you, a dropped tray, a raised voice, sends your heart pounding and your body bracing, as though danger were right there in the aisle. You know, logically, that you are safe. Your nervous system has not caught up. For many people living with trauma, this is simply daily life. I want to say something clearly at the start. This is not weakness, and it is not something you should just get over. PTSD, post-traumatic stress disorder, is one of the most misunderstood conditions I meet in my work. Some people dismiss it, others assume it is permanent and unfixable. Both are wrong. It is a real clinical condition, with a clear pattern and, importantly, some of the most effective treatments in all of psychology. The evidence tells us that around 60 to 70% of people who engage with trauma-focused treatment improve significantly, and many recover fully. Let me start with what PTSD actually is. It can develop after someone is exposed to a traumatic event, one involving actual or threatened death, serious injury, or sexual violence. But a hard experience on its own is not the diagnosis. In the first days and weeks after a frightening event, most people feel shaken, sleep poorly, and relive what happened. That is a normal acute stress response, the nervous system trying to process something that overwhelmed it. For many, it settles on its own, especially with safety and support. PTSD is diagnosed when the distress does not settle, when it lasts more than a month and starts to interfere with work, relationships, and everyday life. When it does persist, it tends to show up in 4 clusters. The first is intrusion, the memory forcing its way back in through flashbacks, nightmares, and sudden distress when something reminds you of the event. The second is avoidance, steering away from the people, places, thoughts, and feelings connected to the trauma. Avoidance brings short-term relief, but it stops the brain from filing the memory away, so it quietly keeps PTSD alive. The third is negative shifts in thinking and mood, things like shame, guilt, feeling cut off from loved ones, or losing the ability to feel good at all. The self-blame here, the endless "why didn't I do something," is often the most painful pattern I see. The fourth is heightened arousal, being constantly on guard, jumpy, irritable, unable to sleep, and struggling to concentrate. Here is a point I always make. Not everyone who lives through trauma develops PTSD, and that is not about strength. Around 7 in 10 Australians will experience at least one traumatic event, yet only about 1 in 8 will develop PTSD. Its presence is not a moral verdict. Several things shape the risk. The nature of the event matters. More severe, prolonged, or personal harm, especially assault or abuse, carries higher risk than events we witness from a distance. A history of earlier trauma, particularly in childhood, raises vulnerability, as does past depression or anxiety. What happens straight afterwards matters too. Isolation and a lack of support increase the risk, while strong connection and a return to safety help protect against it. It also helps to know that trauma is not all one thing. A single incident trauma, like a car accident, a robbery, or a workplace injury, usually has a clear beginning and a fairly focused course of treatment. Complex trauma is different. It grows from repeated or prolonged harm, often at the hands of other people, and it can reach into a person's sense of self, their emotions, and their relationships. So treatment is slower and more carefully staged. Developmental trauma happens in childhood and shapes how safe relationships feel for the rest of life. Then there is workplace trauma, including the cumulative toll on first responders and healthcare staff, and refugee trauma, where layers of violence, a dangerous journey, and the strain of resettlement sit on top of one another. Each of these needs a slightly different approach. So what actually helps? The strongest evidence supports trauma-focused psychological treatments. Trauma-focused CBT combines education about trauma, calming skills, gentle challenging of stuck beliefs, and carefully paced contact with a memory, so the brain can learn it as a past event rather than a present threat. Cognitive processing therapy, or CPT, works on the specific stuck points. Beliefs like "it was my fault" or "the world is completely unsafe." Prolonged exposure gradually helps you approach the memory and the safe situations you have been avoiding, until the distress eases, and EMDR uses gentle bilateral stimulation while you hold the memory in mind, offering another route to the same goal. All four are backed by strong research and current clinical guidelines. If any of this sounds like your experience, please know that PTSD is treatable, and that reaching out is a sign of strength, not failure. In my practice, pacing is everything, and we only begin the deeper work once you feel steady and prepared. You can read the full guide, or book an appointment with our team at Potentialz Unlimited in Vista, using the links in the description below. Before you go, here's a quick recap of what we covered. What PTSD really is. The 4 symptom clusters. Why not everyone develops PTSD. The different types of trauma. The treatments that work.